Welcome back to Unit 8, Lesson 3. This is part 2 of the video, and this part's optional unless you've missed class. So, how do we actually change the volume and pressure of the thoracic cavity in order to get air in and out of our lungs? Okay. First one we're going to show here, we're going to go down to there, and this is inhalation, the first picture. And this is what we call the active phase of ventilation, because our nervous system is actively causing our muscles to contract, allowing us to increase the volume of the thoracic cavity. Okay, so what happens is, down here is our diaphragm, that nice and big and obvious. This is the diaphragm. And normally our diaphragm actually sits way up like that. So in inhalation, the diaphragm contracts and pulls down. At the same time, in between your ribs, you have muscle called your intercostal muscles. Intercostal muscles. So while the diaphragm's contracting and pulling down, the intercostals, which is a nickname for intercostal muscles, pull the rib cage up and out. You can feel yourself do that. Take a big inhalation. Feel your rib cage move up and out. The combined action of the diaphragm pulling down and the rib cage pulling up and out increases the volume of the thoracic cavity. And thus blanks the pressure relative to the external air. If you said decreases the pressure relative to the external air, you're correct. Causes air, so the pressure in the external air is higher, and causes the external air to flow into the lungs where the pressure is lower. And thus we inhale. We don't actually suck in breath. It's forced in from the outside because the pressure is lower. Exhalation is considered the passive phase of ventilation because the muscles relax. So what happens is diaphragm relaxes and domes up, so its relaxed position is up high in your thoracic cavity, and the intercostals relax, and rib cage falls down and in. This decreases the volume of the thoracic cavity. And thus blanks the pressure. If you said increases, you're correct, such that air flows out of the lungs. Now, if you remember the other day, we talked about a pneumothorax, where you puncture your thoracic cavity. So the problem with a pneumothorax, equals punctures the cavity, is that your lungs will no longer inflate or deflate when you puncture the cavity, because what happens is the air pressure is equalized straight across through that hole, as opposed to the only way of equalizing it is it being forced down through your trachea and into your lungs. So as soon as it's punctured, you ruin the airtight cavity, you can no longer inhale or exhale, hence the severe problem. If you cover that puncture and then helps assist someone with breathing, they should be able to survive. Just noted that I spelled diaphragm wrong there. Left out the R. Okay, so let's put a little note down here about that. Pneumothorax, puncture of thoracic cavity. Allows air pressure to be equalized by air entering the puncture instead of the lung. Hence inhalation, and of course not only entering but exiting that way. Inhalation, exhalation ceases. Okay, so our breathing is controlled by our nervous system. At first, in general, our breathing rate is automatically controlled. So for most adults, our breathing rate is approximately 12 to 20 breaths per minute, or what we call ventilations per minute. Okay, and our breathing, if this is the brain, this is a poor drawing of a body, but it'll help for this purposes. If this is the brain, and this is the brain stem, and here's the pons, what's that thing down just below the pons? You said your medulla oblongata. Excellent. So the medulla oblongata, as mentioned in the circulatory system, cardiovascular system, contains the respiratory control center. Okay. And typically, can automatically initiate breathing. So auto breathing plus responds to nervous and chemical inputs. So let's look at the automatic control. Automatically, it will send signals via the phrenic nerve down to the diaphragm. Okay, so this is what we call the phrenic nerve. The phrenic nerve causes contraction of the diaphragm. And the way I remembered the phrenic is the one for the diaphragm. It's pretty easy. The pH for phrenic goes with the pH in diaphragm. Okay, so phrenic nerve from medulla oblongata, MO, causes the diaphragm to contract. At the same time, we have intercostal nerves attached to the intercostal muscles. And step 2, we'll label this here, intercostal nerves. We go down here. At the same time, intercostal nerves from MO cause the intercostal muscles to contract. This combined process equals inhalation and is the active phase of ventilation. But try as you might, there's a maximum amount you can breathe in. And that's due to the fact that coming off the bronchioles, there we have our alveolar, or alveoli. In the alveoli, we have what are called alveolar stretch receptors. This is what's preventing you from breathing in so far that your lungs pop like a balloon. The alveolar stretch receptors signal back up to the medulla oblongata to inhibit the signals to the phrenic and intercostal nerve. Okay, so via what's called the vagus nerve. We talked before about how the vagus nerve is related to sending signals to the heart. It also sends signals back and forth from the lungs to the medulla oblongata. So in step 2, we'll call the greens were 1, the reds 2. In step 2, the alveolar stretch receptors signal via the vagus nerve to the MO, medulla oblongata, to inhibit the phrenic and intercostal signals, causing the relaxation of the diaphragm and the intercostal muscles to equal exhalation. That's the nervous control. Then, chemicals can also play a role. In particular, the MO, medulla oblongata, directly responds to high CO2 and high H+ concentrations in the blood, causing increase in rate and depth of breathing. So it's going to send more signals via the phrenic and the intercostal nerves. Now, the reason the heart is in here is because it also indirectly influences the medulla oblongata. So in our heart, we have, well, basically not our heart so much as our aorta. We have two sensors. So the first is what's called, it's in our carotid artery, so they're called carotid bodies. And over here, I know the diagram's getting messy, I apologize. We have our aortic bodies. Now, interesting, the medulla oblongata is not capable of sensing dropped O2 levels. Rather, the carotid and aortic bodies sense low O2 concentration in blood and signal respiratory control center. In your medulla oblongata, your MO, to increase rate and depth of breathing. So while the MO can directly sense increased CO2 levels, which would also be accompanied by increased hydrogen levels due to the way that the carbonic acid breaks down into H++ as well as bicarbonate ions. You're going to momentarily increase your H+ ions before it binds to the hemoglobin, and that's detected by the medulla oblongata. Okay, but in contrast, O2 levels are not directly detected by the medulla oblongata, but rather by your carotid and aortic bodies, which then communicate with the MO. Okay, so that's how we control it through our nervous system. The last thing we need to take a quick look at is just lung capacity. Okay, now your total lung capacity, in theory, for most adults, is approximately 5.8 liters, but we never use all of this. Okay, what we have are two key volumes. The first is called tidal volume, And you can go back up and spend some time looking at this graph and reading it, and I recommend you do, because it's really important that you do practice reading graphs. We will in class. The tidal volume is total amount of air moved in and out in a single normal breath or ventilation. So a breath or ventilation is both in and out. And for most people, this is approximately 500 mils. 2 cups. 1 cup in, 1 cup out. Okay? Then you have what's called your vital capacity. This is the max amount of air moved in and out in a forced breath. So if you try as hard as you can to bring as much in and as much out. And in most people, this is approximately 4.6 liters. If you have some sort of respiratory illness, that can be drastically compromised. As well, you have what's called your expiratory reserve. This is amount you can force out past a normal exhale. And this is approximately 1.4 liters. And that again will go down if you have respiratory issues. You have your inspiratory reserve volume. This is the amount you can bring in or force in past sorry, I had to fix that. Past, not I wanted past. Force in past a normal inhale. And this is approximately I'll check, approximately 3 liters, though it's significantly less in females. And finally, you have what is termed the residual volume. And this is amount that remains in your lungs no matter how hard you exhale. And this is approximately 1.2 liters. So there's always air, no matter how hard you breathe out in your lungs, and this keeps your lungs from collapsing. Okay? So that's it for the mechanisms of how we breathe. If you have any questions about this, please come see me. Otherwise, I hope you have a great day, and I'll see you in class.